So motion accounts for imaging problems during fluoroscopy, more for children than for adults. Hard to hold a child still. A lot of things you can use. I'm sure you've seen text for some of the older kids, you know, okay, turn on the positioning light, okay, blow out the candle, blow out the light. It's all sorts of things you do. But for the little ones, all they do is squirm. So, as busy as the day is, you need to establish a friendly, non-threatening rapport with the child. I always kept a teddy bear in the room for kids. The hard part was getting them to let go of it when they left. But big smiles help no matter how bad the day is, no matter how difficult the case is. A big smile does wonders with kids. Speaking slowly and speaking to them and explaining in a way that a 2 or 3 or 4 or 5-year-old will understand. We're taking a picture. Don't use the word x-ray. I need you to hold real still. Can you smile for me? There you go. Okay, give me a big smile, taking a deep. So there's things you can do.
I use that for all my patients.
How many of you have kids? Okay, so use your own experiences for when you want your kids to do something they really don't want to do.
Scream at him.
Okay.
That's an exception over there.
You want to practice the necessary breath holding or position changing. So you can have them practice. You can even use, and it takes some time, you can use the positioning light because it goes off all by itself. So, okay, so it's going to be on like this. You hold real still, then the light goes off. Okay, now we're going to change position. And you hold this position. They can see the light. They can see them that they don't move. And you tell them the light will go out when I make the exposure. You'll hear a beep. Tell them when they can move. Anesthesia or sedation may be necessary for long examination periods. There are all sorts of protocols that hospitals use for sedation, especially for kids. You want to make sure that you know what those protocols are, and the reason is because some hospitals, if they're short-staffed, will not send you the personnel that need to be there for conscious sedation. So, when your patient walks in the door or drives in the door on their gurney or their wheelchair, who's in charge? Who's in charge? You are.
Me.
Your room, your procedure. If there's a physician in the room, then the physician's in charge. But if it's just you, you're the tech. Your equipment, your procedure, your protocol, your patient. Now, nurses will give you all sorts of grief about that. Well, this is my patient. Yeah, but this is my room, my exam. You need to do and follow my instructions. Okay? I've had lots of interactions with nurses. They don't like it, but they need to follow direction. When they are told to go stand in a particular place, they need to do it. When they're told to put on an apron, they need to do it. Okay? But you just want to make sure that whatever the protocol requires for sedation, that all of those people and all of those things are there in place. That does not include the parent. Immobilization devices, Velcro, sandbags, things like that work really, really well. If all else fails, the child will need to be held. Who holds?
Parents. Parents and children.
Or, if it's a case of conscious sedation, guess what the nurse gets to do?
Oh, yeah.
Put this apron on, put these gloves on, hold this patient just like this. That's who holds. For routine types of things, extremities, knees, things like that, yes, you can have a parent gowned and hold. But if the exam is complicated enough that that child needs to be sedated, my recommendation, you need to check the protocols of your facility, but my recommendation is you don't have the parent in the room. Because if that child goes sour, or codes, or has a problem with sedation, the last person you want in the room is a parent. But again, find out what your protocols are for the facility that you work in. There's all sorts of things you can use to hold down kids. Personally, I think these types of devices terrify the child more than sandbags, pillows, or just somebody to comfort and hold them. Okay. Can a technologist routinely hold?
Routinely?
How many say yes? How many say no? The answer is no.
Not routinely.
Technologists are never allowed to hold on a routine basis. You hold only if you have no other options. Drag in a nurse, drag in somebody else. You will be asked as students to be routinely holding. No. Okay? If somebody is asking you to routinely hold patients, you need to let Ms. Mitz know. You need to let your clinical supervisor know. You can let me know. That is not allowed, especially students. Okay? TAM board can use, kind of depends, frankly. You know, for little ones like this, especially if you're up in NICU, you know, you let the nurse, you put gloves in the thing, they put one hand here and one hand on their little arms and take one, maybe half a mass at 50. You know, you can do those all day long and the nurse's badge won't even read. Okay. So, in cases where sedation or mechanical method of immobilization are not practical, parents or hospital personnel must immobilize the child. Be cautious of scatter radiation for patients. Use of apron and lead gloves are recommended for whoever holds patients. Gonad shields have to be at least 0.5 millimeter lead equivalent. Genetic effects are thought to be cumulative, but let me say again, based on the information we have, diagnostic procedures have never been found to produce genetic effects. Artifacts, to remove or not to remove? Do you remove a t-shirt? You remove. Shorts?
If they got a zipper.
Everything.
I say
Remove.
everything but your underwear, man.
Bandages. Remove if you can. Diapers?
No.
Remove.
Why do you remove the diaper? Does it depend on the x-ray?
Yeah.
Okay.
I mean, if you're doing a chest, you don't need to take
That's
the
why I was
diapers off.
asking.
Yeah, no.
Okay.
Yeah, it's yeah.
Only if it's going to be in the anatomy? In the...
Yeah, you have to worry about what kind of things are going to show. Again, in your own, now these are typical rules of thumb. In your facility, you will have a pediatric protocol that tells you specifically what to remove and what not to remove. What the radiologists have looked at and said, I know what a t-shirt looks like, don't worry about it. As long as there's no folds or creases. I know what a diaper looks like. Okay. Problem with diapers though is if the patient's had anything that's excreted in the urine that's like an iodine-based dye, you've got to take that diaper off, and you may actually have to wash with a washcloth to get it off the legs, otherwise it's going to look, you're going to see it. Automatic brightness control reduces patient exposure. What's the difference between AEC and ABS? Automatic exposure control is for radiography. ABS, automatic brightness, is for fluoroscopy. Okay. Distance. You want to decrease the eye tube distance to the patient? Oh, that was a picture of me when I was a kid. Smallest collimation possible, no grids, digital spot images if it's available. And that's it. Anybody have questions? Drive safe.